Hello, bonjour. Welcome, and thank you for joining us for this information webinar for our new program, Manitoba Appropriate Use of Antipsychotics in Long-Term Care Collaborative. I'm Nicole Pollock, Senior Program Lead on the Health Innovation Programs team here at Healthcare Excellence Canada. My pronouns are she, her, and I have the honor of being your host today. We are pleased to offer French simultaneous interpretation for this session. If you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. We invite you to share your questions and comments at any point during the webinar in English or French by typing into the chat box. We'll look to address as many of your questions as possible during the Q&A session near the end of the webinar. If you need support at any time, you can reach out to our tech support using the chat feature. This session is being recorded and will be available on our HEC website in the next couple of days. So I want to start by acknowledging that I'm joining you from Anishinaabe, the traditional territories of the Anishinaabe people, colonially known as Ottawa. I recognize and appreciate my ability as a settler to live here with my family. Healthcare Excellence Canada is also located in Ottawa with staff all across the country. HEC honors the traditional territories upon which our staff and partners live. Truth and reconciliation is an ongoing journey, and as an organization and individuals, we must commit to not repeating past mistakes and to work towards more equitable and respectful relationships with First Nations, Inuit, and Métis. I invite you to share who you are and where you're joining from in the chat box. And it's nice to see lots of people already introducing themselves. So a bit about Healthcare Excellence Canada, if you're not yet familiar with us and what we do. HEC is an independent, not-for-profit charity funded primarily by Health Canada. We convene and connect people across the country to spread and scale quality and safety improvements, strengthen capacity and collective leadership, and catalyze policy and practice change. Our strategy to shape a future where everyone in Canada has safe and high-quality healthcare largely focuses on the care of older adults with health and social needs, including improving the quality of life and safety of those living in long-term care. The objectives of this webinar are to provide information to personal care homes in Manitoba about this upcoming HEC program and the opportunity to improve the appropriate use of antipsychotics in your homes. So the agenda will include context from our partner, Shared Health, on why this is an important issue to be addressed and why now, details on the supports HEC will offer as part of the collaborative, share more about the successful AUA approach, which was first developed in Manitoba, hear from leaders at a personal care home on the impact of this work, and lastly, we'll review the online portal registration process and answer any questions you may have. So I'm excited to welcome our speakers who will be sharing the screen here today. Cynthia Sinclair is a coach and advisor with HEC. She's a retired registered nurse with over 35 years experience. She has served in a variety of roles within the Winnipeg Regional Health Authority, was director of care for a large Winnipeg home, and CEO of a home in England. Cynthia is a graduate of HEC's Extra Executive Training Program, where her intervention project with Joe Puchniak set the foundation for future AUA collaboratives across the country, including this one. So we're very grateful to be working closely with her again. And Joe Puchniak is the Provincial Clinical Service Lead for Home and Community Care with Shared Health Manitoba. He has over 22 years of healthcare experience spanning national, provincial, regional, facility, and clinical patient levels. Together with Cynthia, he co-led the original work on the appropriate use of antipsychotics approach, and he's now helping to bring it home to Manitoba. Joe holds a Master of Social Work from the University of Toronto. Dr. Ashley Buehler is the Provincial Personal Care Home Medical Specialty Sublead with Shared Health Manitoba. She also serves as the Chief Medical Officer for Deer Lodge Centre, Middle Church Home, River Park Gardens, and Golden West Centennial Lodge. Specializing in geriatric care and chronic disease management, Dr. Buehler leads multi-site clinical teams to elevate patient quality of life and drive excellence throughout Manitoba's healthcare system. Cindy Bialik is Manager of Health Services for Eastgate Lodge Personal Care Home, where she has worked since 1982. Cindy started as an after-school lunch girl and eventually became a healthcare aide, floor nurse, CRN, and now manager for 20 years. Cindy has also worked at Beausejour Hospital, St. Boniface Hospital, and Deer Lodge Center, and has always loved working with elderly residents. Shay Carbonic Brown is CRN at Eastgate Lodge Personal Care Home and previously worked at Beacon Hill Lodge. We're so grateful to have Cindy and Shay here to share more about their previous AUA initiative supported by HEC. And then last but not least, my colleague Kirby Curvin will join us to share more about how you can register for this collaborative online on HEC's portal, and that opens today. So once again, feel free to drop any questions you might have into the chat box throughout the presentations. And without further ado, I'll turn it over now to Ashley and Joe.
Hello, everyone. Thank you for joining us today for this wonderful presentation. I'm going to share a little bit about Shared Health and the background. It's Manitoba's provincial health authority providing provincial planning, health services, and operational support for Manitoba's health system. It's a bilingual health authority and it has multiple employees working all across Manitoba. The overarching theme of Shared Health is to provide high-level provincial overview of big ideas, projects such as this one, and help bring it down to a more personal level, not only for the patients we're helping to care for, but to each of the areas as well. Next slide, please. The project that we'll be working on and talking about is antipsychotic use in long-term care in Manitoba. Why is this important? Next slide, please. So across Canada in general, about 1 in 4 long-term care residents are taking potentially inappropriate antipsychotics, which can increase serious health risks to the individual. And a lot of these individuals are taking antipsychotics without a diagnosis of psychosis. As we are all generally people working in long-term care, I don't think this is a surprise for anyone, but it is a big concern nationally, and we want to be able to try to improve this. Next slide, please. Last year, in June 2025, was the first time a national target has ever been presented to Canada, and an updated guideline came in relation with that. So Canada's national target for antipsychotic use is 15%, and the panel that came up with this recommendation recommended this target as a quality indicator for potentially inappropriate use of antipsychotics in long-term care. They were very clear to recognize that the goal is not to immediately get to 15%, so an annual improvement goal of 15% per year was also recommended in order to reach the overall national target of 15%. Next slide, please. Since this announcement occurred, we have been doing a lot of things in Manitoba. So through our Shared Health Committee, we've been doing a lot of outreach and information about appropriate use of antipsychotics in long-term care. All of these resources are available on the Personal Care Home's Shared Health website. We've put out memos about appropriate use of antipsychotics, antipsychotics briefings, information for residents and families so that they're informed about medications that their loved ones are on, as well as information for prescribers and providers as well. Additionally, we are working with the Provincial Geriatric Psychiatry to provide educational rounds for providers and physicians to be informed on this project, be better informed about the behaviors of concern, as well as antipsychotics in general, to make sure that we are all reaching the appropriate targets and utilizing antipsychotics appropriately for things like psychosis and not necessarily for things that aren't indicated as well, such as insomnia. Next slide, please. I will hand it over to my colleague, Joe.
Thank you very much, Ashley. So now we're shifting to look at some of the data for Manitoba on this topic. This data is taken from the DPIN system, which is the drug dispensing data for Manitoba. This slide shows the provincial percentage of PCH residents on an antipsychotic over the past 2 years worth of data. So we're seeing overall general improvement recently over the past year across Manitoba, which is really great to see. Our current most recent provincial rate is approximately 30% and is on the decline. This data includes the large majority of licensed PCHs across Manitoba. However, there are 15 PCHs in Southern Health that we're not able to include in this data yet. There is work happening to include those PCHs in the future with our reporting. Next slide, please. So this slide shows the percentage of PCH residents on an antipsychotic medication for each health region across Manitoba. You can see that there are different trends happening across each health region. Of note, we can see that IERHA, Interlake Eastern Regional Health Authority, has been experiencing a significant, consistent improvement over the past 6 quarters of data. I know they've put intense effort into this work, and the data shows the significant positive progress they have achieved, and really what is possible using the AUA approach across an entire health region. You'll hear more about this later in today's webinar. And I also want to mention that there is other great work happening in other sites in other regions across Manitoba, and we really want to build on that great work with this collaborative project. Next slide, please. So this slide shows the number of licensed PCHs across Manitoba. You can see there are approximately 9,500 beds across 5 health regions in Manitoba. Next slide, please. So of those approximately 9,500 beds in Manitoba, based on the most recent drug dispensing data, approximately 2,850 residents living in Manitoba PCHs are prescribed an antipsychotic medication. That is a large number of people receiving antipsychotic medications, and we're excited to do some great work with you all to continue to lower that number. So taking this further, for example, if a PCH has 100 residents, on average, 30 residents would be prescribed an antipsychotic medication, many of whom would benefit from a deprescribing review. So this slide really is here to give you an example to show overall in Manitoba how many people are on antipsychotics and an example of one PCH. Next slide, please. So appropriate usage of antipsychotics is a new high priority safety quality dimension that will be evaluated by Accreditation Canada in May 2027 when long-term care is evaluated next year. This collaborative is a great opportunity to help PCHs, health regions, and our whole province get prepared for next year's Accreditation Canada visit. So really want to highlight that a great opportunity to join this project, as we know this Accreditation Canada visit is coming next year. Next slide, please. So I'll pass it over to Nicole here, but before I do, on behalf of our Shared Health Home and Community team, we would really like to thank Nicole and her whole team for partnering with us on this important work. It's really a great opportunity to drive quality improvement across Manitoba PCHs, and we're very thankful for HEC's support, expertise, and partnership in this work. So over to you, Nicole.
Awesome. Likewise. Thank you so much, Joe and Ashley, for providing this overview on the current state and the opportunity to work on improving the appropriate use of antipsychotics and person-centered care in Manitoba. We are also very grateful for the partnership with Shared Health and their guidance on the provincial context, and for leading the promotion and recruitment across the regions to join the collaborative. And supporting data collection and provincial alignment for the collaborative. So then Healthcare Excellence Canada will be delivering program content and providing coaching and learning activities and leading the evaluation. So it's my pleasure now to share more about this new program. Next slide, please. So building on the success and impact of past AUA programs, HEC's objective is to now spread and scale this approach to all personal care homes across Manitoba. Secondly, aligned with HEC's strategy, the objective is to advance person-centered care approaches to improve the quality and safety of care for residents, care partners, and staff in long-term care. And thirdly, to build capacity to do quality improvement and measurement work. So here's a snapshot of the timeline for the program. Registration opens today through the online portal on HEC's website, and it will be open all summer until September 11th. And as homes register for the program, they'll be assigned to a coach and have a one-on-one onboarding call together. Then in September, the program activities will begin and continue for 1 year, mostly taking place within monthly regional group coaching hubs. There will also be province-wide virtual events next May and November to bring homes together across the regions and celebrate progress and impact provincially. So whether your team is just setting out on your AUA journey or have already seen promising results, this collaborative is designed to help you progress with step-by-step and wraparound supports. So the main focus will be on coaching within the regional group hubs. So we'll go over that in more detail. And there will be support to learn the foundations of quality improvement and measurement through hands-on workshops, which I'll also tell you more about. There will be opportunities for homes to champion the AUA approach by sharing their stories with their peers one-on-one and within the regional coaching groups, and to be showcased across the province. The online portal on the HEC website will have curated step-by-step learning activities, videos, resources, and tools to support homes to implement the AUA approach. And teams will receive a monthly emailed bulletin with any new opportunities, resources, and reminders. So more about the coaching hubs. Participating homes will be assigned to group coaching hubs with about 10 other homes from within their region in order to optimize the peer-to-peer sharing and learning within the local context. And this is where the coach and the homes can really roll up their sleeves and work together to plan their initiatives, check in on progress, and troubleshoot issues. They'll meet on a monthly 90-minute call throughout the program from this September to next October. Teams can access asynchronous learning activities when it is convenient for them, like reviewing a tool or watching a short video in preparation for the hands-on workshop during the coaching hub. And yeah, as I mentioned, there will be support to learn the foundations of quality improvement and measurement through hands-on workshops, and support throughout your improvement journey, including how to get started planning a quality improvement initiative with an improvement charter, how to write a problem and aim statement, how to do a plan, do, study, act cycle, how to plan for sustainability, and how to measure whether your changes result in improvements. So along with 10 other organizations, HEC is a member of the Appropriate Use Coalition led by Choosing Wisely Canada with support from Canada's Drug Agency. And as Ashley mentioned, in 2024, an independent panel of experts reviewed evidence from Canada and abroad to set a national goal for reducing potentially inappropriate antipsychotic use in long-term care. In alignment with that target, the aim of this collaborative is for each personal care home to reduce the potentially inappropriate use of antipsychotics by 15% by the end of the program in September 2027. So it may take time for a home to reach a 15% rate overall, but a 15% reduction as an improvement goal is achievable, and we will support participants to calculate what that would look like at their home and to create a realistic plan to achieve their aims step by step. Part of the quality improvement process will be to thoroughly analyze your list of residents on antipsychotics and discuss with your interdisciplinary team which residents may be appropriate to reduce, taper, and or discontinue when it's safe to do so. You'll be coached on how to monitor whether your changes are leading to improvements and asked to report quarterly on how you're doing against these set measures. So of the residents identified as potential candidates for deprescribing as part of your quality improvement initiative for the year, how many have had a reduced dose in the last quarter? How many have been discontinued? And we'll also discuss balancing and process measures and how they can help you monitor your progress. So lastly, related to measurement, we'll have lots of supports throughout the collaborative, but we wanted to quickly let you know about a learning opportunity that CIHI is hosting just next week. It's a client support session, but it's open to anyone interested in learning more about the quality indicator, potentially inappropriate use of antipsychotics in long-term care. There is a maximum capacity of 500 registrants for that webinar, so register soon if you are interested. And now I will turn it over to our trusted advisor, Cynthia, to tell you more about the AUA approach and its origins in Manitoba.
Thank you very much, Nicole. There we go. I finally got my video to go. I'm pleased to be here with all of you today, and I am going to spend a little bit of time talking about the AUA approach. As has already been said, the Manitoba Collaborative Curriculum was designed based on HEC's successful AUA approach. Some of you might be familiar with it if you have participated in past collaboratives, but the diagram shows how to use the AUA approach to care in practice. Throughout the collaborative and together with your coaches, you will explore these pillars in more detail. But let's go through it very briefly right now. The first step will be to conduct the medication reviews. That's the bottom right-hand corner there. This process should be multidisciplinary and focus on the resident history, their diagnoses, their inclusion and exclusion criteria for deprescribing antipsychotics, a time frame for deprescribing, as well as the creation of a person-centered care plan. The second pillar is to enhance supportive care, the little green circle there. Person-centered care strategies will focus on the care needs and wants for each resident and their family or care partners. So this will require teams to consider really creative opportunities for engagement. Like I like to say, think like there is no box. It will also require very detailed individualized care plans and activities, and also fostering a home-like environment as much as possible. The third pillar is to take a full team approach. This work requires the entire team to be involved, not just the nursing team. And the team is usually together through huddle discussions to formulate plans and approaches. Management involvement is key for this approach because management can help to break down those operational barriers for creative solutions, and also to help departments work together more collaboratively to achieve results. Prescribers and care teams can help to encourage communication and collaboration. And of course, we don't want to forget that family and essential care partners need to be included in the team. They are essential. Next slide. The fourth pillar is to deprescribe as appropriate. And once the medication reviews are completed and you have selected your residents and the full team has been engaged and a person-centered care plan is in place, then an intentional deprescribing strategy can begin. And finally, as Nicole talked about, you will collect and monitor data. You will track outcome measures to ensure that the changes you are making are offering an improvement. Your data can include the quarterly assessments for CHI and the Inter-RI, can include pharmacy data or other quality indicators, behavior mapping, recreation data, and family feedback. What's important is to not just collect your data, but to share it with your team and to celebrate your successes. Next slide, please. I want to talk just briefly about the past AUA quality improvement programs and how this started. As was indicated earlier, Joe Puchniak and I joined the extra program as a team in 2011 and 2012. We wanted to demonstrate the power of data in quality improvement, and so we chose the appropriate use of antipsychotic indicator from the Inter-RI. Together, we developed a very comprehensive program and worked with a pilot home in Winnipeg over the course of a year or so. And our results were very positive and significant. And as Nicole said earlier, it became the forerunner for HEC's AUA collaboratives. And from that point, it has spread. HEC has a long history leading national and regional quality improvement programs that have shown success in supporting the appropriate use of antipsychotics. And we started with a national AUA collaborative in 2015, and then carried on with some provincial scale-ups, including New Brunswick, Newfoundland, Labrador, Prince Edward Island, and Quebec. Next slide, please. What is important is the success of the AUA approach. It's been consistent throughout the years, and that's what makes it exciting and proven. The results that we've achieved include safe reductions and discontinuations of antipsychotic medications for residents. Over half of participating residents have enjoyed either a reduction in dose or complete discontinuation of the medications. In addition, we've seen no increase in responsive behaviors, and that's important. And perhaps the most important result, I think, is the improvement in resident quality of life. We've seen improvements in independence, improved mobility, improved social engagement, and fewer falls for residents, all making their lives much better. We've also seen improvements in staff culture and an improvement in how teams engage with families. Next slide, please. So our most recent program, Sparking Change in AUA, which just recently finished up, also offered supports based on the AUA approach. Our final report submission showed really positive outcomes. As you can see on the slide, 66% of targeted residents were able to fully discontinue antipsychotics or reduce their dosage. And that works out to 889 residents living across Canada. That's a large number. 86% of teams who submitted for the final award said they saw a reduction in the number of targeted residents on antipsychotics. And in tracking our balancing measure of restraint use, there was a 30% reduction in daily physical restraints. The home-level initiatives that led to these results were focused around providing person-centered care. And as one submission put it, quote, staff shifted from asking what medication was needed to asking what the resident was communicating and how care approaches and the environment could better support comfort. So we're shifting our thinking and we're shifting our culture. There were a number of Manitoba homes that participated in Sparking Change this last year, and they all did quite well. In particular, as was already mentioned, the homes in the IERHA have enjoyed significant success and have sustained their gains. I am hopeful that many of the homes that participated in Sparking Change or other collaboratives will continue to sign up for this Manitoba collaborative. It will give them an opportunity to deepen their knowledge of quality improvement and the AUA approach, and to share their experience and expertise with other homes. I look forward to working with all of you over the coming year. And with that, I'm going to hand it over to Cindy and Shayla to discuss their exciting progress at Eastgate Lodge. So over to you.
Thank you, Cynthia, and thank you for having us here this afternoon to share with you our successes at Eastgate Lodge. Next slide, please. So Eastgate Lodge is a personal care home composed of 2 care units and a 20-bed dementia unit designed to provide individualized, comprehensive care in a home-like environment. Next slide, please. Some of the challenges that we faced here at Eastgate was lack of deprescribing antipsychotics after admission with medication, COVID restrictions, high turnover of staff during COVID, a shortage of staff as well, lack of education and resources, lack of behavioral monitoring, lack of understanding why a resident was on an antipsychotic, lack of the medical records on admission, and lack of understanding of antipsychotic implications on the elderly. Next slide, please. So our goal was to reduce the use of antipsychotic medications by 15% over the next 12 months, aiming to reduce by 7% in the first 6 months through the implementation of evidence-based strategies, staff education in dementia care and pharmacology, and individualized care plans to enhance non-pharmacological approaches tailored to resident likes. Our aim was to monitor admission processes and utilize behavioral mapping with all new admissions admitted with antipsychotics. Next slide, please. Some of our key activities and goals. So goal 1 was staff education and training. We targeted training 100% of Eastgate Lodge staff on non-pharmacological interventions and psychological symptoms of dementia within the first 12 months. We targeted all nurses and healthcare aides to be trained within 6 months in de-escalation techniques. We ensured that staff had attended the IRHA dementia care education and offered staff to go again as a refresher. We were also fortunate to have all of our staff on our dementia unit attend the PART education. We were also fortunate to have our pharmacist, Sam Schuster from MediSystem, do a presentation for all staff on the use of antipsychotics. Goal 2 was implementing the use of non-pharmacological interventions. We tried to expand the use of non-pharmacological approaches, such as ensuring individualized care plans, including resident-specific therapies, environmental modifications, such as bird feeders at the windows, making units more homey with decor, making our linen carts, etc., presentable. Our goal was for recreation to become more involved with one-to-one programming for residents on antipsychotics. We are fortunate at Eastgate Lodge to have a recreation worker on our dementia unit from 2 o'clock to 7 o'clock every evening. And this helps to provide a calm environment and de-escalate behaviors. We purchased and enhanced busy boards, games, dolls, and fidgets on the unit. Tailored music therapy to the genre for the elderly population instead of the radio. As times the staff would like to put the radio on or put some rock music on, but we all know that that sometimes increases behaviors and is just too overstimulating for the elderly. Goal 3, regular medication review. We had pharmacy provide us with a list of residents on antipsychotics and benzos prior to medication review to discuss and monitor residents closely in preparation for the medication review, ensuring staff can focus on deprescribing. Goal 4 was to monitor resident safety and well-being. We never want to negatively impact residents' lives and abilities, and our team closely monitored for adverse reactions from deprescribing, which included DOS monitoring and vital signs daily. One gap we identified during this time related to new residents being prescribed antipsychotics in the hospital and never being reassessed or assumed that these residents were on this medication for mental health. But in many cases, it was due to reactive behaviors at the hospital or exit-seeking behavior, calling out, etc., that could not be managed in that type of environment. After identifying this gap, we initiated DOS paperwork on all new residents admitted with antipsychotics. Next slide, please. Some of our person-centered activities. So painting. We also painted the unit. Shay, the CRN, along with her team, picked colors. They did research on colors that would be appropriate for the dementia unit. Building activity boards, buying magnetic tiles, projectors, baby dolls, etc. On our unit, we had residents that were removing the nameplates, removing pictures from the wall, doing quite a bit of damage. So instead, the staff came up with a great idea to put stickers on the walls instead of pictures. Therefore, if the residents wanted to pull the stickers off the wall, they could, and they could replace it back onto the wall without damaging walls, and the unit still looked quite homey. Our nameplates had to be placed above the door. We took a home-like approach and bought beautiful white frames for them. And the picture in the middle is an example of providing the information, but yet making it look home-like. Next slide, please. Our outcomes and results. So our residents feel more respected, heard, and valued as care is tailored to their preferences, leading to a greater satisfaction and emotional well-being. We created a shift of focus, addressing unmet emotional and psychological needs rather than reacting with medications for agitation, aggression, and reactive behaviors. Overall reduction by 20% on adverse events such as falls, sedation, and EPS symptoms and hospitalizations. There was increased family connections. Residents were less sedated. Relationships with families grew stronger with staff and loved ones. We reached our target goal of reduction at 16% and as low as 17% during the tracking period. And this was only on de-prescribing and not reductions. We found it easier at the time to focus on the de-prescribing to keep better track of what our project was. Our residents expressed a feeling more connected with their care, and staff felt more connected with the residents. Staff felt more valued and connected with residents and their place of work. They felt more prideful in their roles and tended to give more ambition to the job. When staff feel more gratitude and satisfaction towards their careers, it reduces staff turnover and allows a consistent environment for our residents to thrive. Thank you. That's the end of our presentation.
Great. Thanks so much. And we're just going to take a few minutes to talk about the registration process. So my name is Kirby Kervin, and I'm a program lead here at Healthcare Excellence Canada. And I'm coming to you today from the unceded traditional territory of the Anishinaabe Algonquin Nation, which is colonially known as Chelsea, Quebec. Today, I'm going to take just a few minutes to walk you through the registration process for the program, which is officially opening today. The next slide. So to begin registration, you need to log into the HEC community portal. You can access this directly from the Healthcare Excellence Canada website by selecting Portal Sign-In at the top bar menu of the page, or by going directly to the link shown on the screen. Once there, simply click Get Started. If you already have an account for the HEC portal, you can simply enter your login information. If you are new to the portal, you'll need to select Sign Up Now to create a new account. To create a new user account, you'll be prompted to enter and verify your email. Once you receive the verification code in your email account, simply input this into the form to complete the verification process. From there, you can complete your user profile and you're ready to go. Once logged in, you can explore HEC's current offerings and learning opportunities. To apply or register for an offering, click the Apply or Manage Programs button to access HEC's program management platform directly from the portal. Here you can view and submit applications for active HEC offerings, invite others to collaborate on your application, and manage reporting. On the home page, you will find a list of active HEC offerings, including our new Manitoba AUA Collaborative. This includes key program details, key dates, and eligibility requirements. To get started, click on the Apply Now button and complete the application form for the program. A few important tips. The portal does not autosave, so remember to save your work regularly using the Save button at the bottom. You can complete your application in multiple sittings as long as it's submitted before the September 11th deadline. You can also invite team members to collaborate, including a co-lead. They'll receive an email with instructions to join your application once they have created a login profile for the system. When your application is complete and you're ready to submit, the Submit button will appear at the bottom right of your screen, but only after you have saved and closed your form. Keep in mind, once submitted, you will no longer be able to make changes to your application. Once submitted, the team lead will receive an email confirmation that their application has been successfully submitted. Once HEC staff have reviewed the application, the team lead will receive an email notifying them that the team has been admitted into the program and must complete their registration by signing the collaboration agreement. To do this, the team lead will need to log back into the system and go to the Signature Clarification Requested section in the gray box on the left-hand side of the screen. Open your application and click Edit at the top right corner of the screen. Go back into your application to complete the last section of the form. You'll follow the same process to resubmit, and that will be sent back to HEC when completed. From there, you'll receive official communication from HEC welcoming you to the program and providing the next steps in getting onboarded and ready for the program to start in September. We do encourage teams to register as early as possible for this program to provide enough time for you to meet with your one-on-one assigned coach over the summer period before programming officially begins in mid-September. If at any time you have questions about the program or how to register, you can always reach out to us at our program inbox that you see on the screen. So that's it for registration. And if you have questions, you can start to put those into the chat box. And I'll hand it back to Nicole.
Amazing. Thanks so much, Kirby. And thank you very much to Eastgate Lodge Personal Care Home. It's always, it's good to talk about the approach kind of at the high level, but it's always amazing to give those examples of exactly what you had done on the ground. And I really appreciate you guys sharing. Thanks also to Shared Health and Cynthia for presenting. So we hope that you all understand a bit more about the design of this collaborative and the supports that'll be offered for homes that register. Again, you can register today to join us on this AUA journey. So yeah, we have lots of time left now for any questions from participants. So please feel free to put any questions you might have in the chat. And a couple have come in already. So there is one common question that I just wanted to address up the top, which is that this collaborative is structured a bit differently than our past few programs if you've participated before. So there will not be any seed funding or award funding opportunities, but the program will be focused on building improvement capacity through the coaching and practical resources and learning opportunities and the peer-to-peer connections. So I see one question, is it open to Manitoba or accessible to other provinces? So this particular program is just to scale up within Manitoba. I know that our colleagues in BC at Health Quality BC also run action series on AUA. So if you're in BC, I recommend checking out their website and of course checking back with HEC or signing up for our newsletter to find out about all of our upcoming program opportunities. So maybe I'll invite Cindy and Shay to come back on camera if they don't mind. Wondering if I could ask you to share a bit more. Thank you, ladies. I was wondering if you wanted to share what was like the one most impactful change that you saw in implementing the AUA approach. If there was one thing you would highlight for those who are new to the process.
What could you highlight? I think one of the most important things, maybe I'm not sure if I'm going to answer your question correctly, is you need to have your staff on board and you need to have staff buy-in. And even if you educate your staff, they're the ones working on the floor. They're the ones dealing with the behaviors on a day-to-day basis. And in the moment, even though they've had the training and all the education, it needs to be reinforced and reinforced. And you have to have you almost have to have the right mix of staff on those behavioral dementia type units. So Shay wanted to say something?
I think the most impactful that we've seen from deprescribing was the increased connection between like residents and staff and residents and their family members. There was less lethargy. They were able to participate in recreation a little bit more. They were having, more impactful relationships with loved ones. So that was the biggest impact that we've seen from deprescribing in our facility for sure.
Oh, that's amazing. And those are the heartwarming stories that really hit you, right? Like, obviously, it's great to see the numbers, and that's really important, but it really personifies like why this is important. Yeah, and Cindy, that's a great point as well. Like, we can make all the best plans, but if you don't have, the buy-in and understanding, and if it's not going to work well for staff, then it's not going to happen either. So, yeah, thank you for sharing. Anything else you wanted to share before I let you off the hook?
I see there is one question in the chat.
Mm-hmm.
Again, did you struggle more with buy-in from staff or families? Was there a lot of concern from families?
Yeah,
I think the staff always had concerns and they always asked why we were doing it. But again, the education, and you have to keep taking the time to explain to the staff why you're doing what you do. But families, they were pretty good.
Yeah, I don't think we really had much concern from families. They actually, I think, really were happy with that, just due to the stigma around antipsychotics for them. So I think that they were really pro reduction, so that worked in our favor. But even as of right now, we're still kind of struggling with the staff buy-in, and they're not really seeing the benefits of it necessarily, especially like on our closed unit, on our locked unit. They're struggling a little bit more there, so they need a lot more support and a lot more education and refreshers. But it has been quite a process just keeping them educated and enforcing that. It's been a lot on me and Sydney to just continuously enforce that, but overall, we've seen a great impact in all of our residents here.
Yeah, no, thanks for sharing. And that kind of like culture change takes time, and like you said, kind of continued education. Yeah. And yeah, great points as well around because we do hear that sometimes in the past. Like it's a great question because we do hear like, what if the family's resistant? But usually it's kind of a lack of understanding about what the benefits would be to deprescribing and those heartwarming stories that you did share. So it's a kind of a barrier that can usually be overcome.
I see there's another question here in the chat as well. Have there been any issues deprescribing, such as an increase in adverse behaviors? Yes, we've had to put some of the residents that we either reduced or took off, we either had to put them back up or change medications. So it does affect everybody differently. So it's close. You have to closely monitor what you're doing. And like we're noticing on our dementia unit, it was going smooth with the deprescribing and the resident flow. And we had some residents pass away and some new residents admitted, and the new residents' behaviors are triggering some of the other residents now. So some of the other residents that we had settled, right now we've had to put heavy work relief in there just because there's so many factors, the environment especially, that contribute to the behaviors and that you have to monitor constantly.
Yeah, and even through our process, like we didn't win them all, right? We did do some deprescribing, and some of those situations, like one in particular, they actually ended up on more antipsychotics than when we deprescribed them. So that was our one off. Everyone else was, really took well to it. But we did have the one resident that ended up on more antipsychotics than previous. So
Interesting.
that's definitely something that we had to consider and look at, and constantly monitoring with DOSes and stuff. But yeah,
maybe I'll invite Cynthia to join us again in this discussion as our expert coach, because I think, it's a great point that it's, the goal is never to just deprescribe everybody. It needs to be monitored and appropriate.
Exactly. And I did type something to that effect quickly in the chat. It's not about everybody off or everybody on. It's about going through the medication review, looking at your residents critically and seeing where the opportunities are for deprescribing. And it doesn't mean that as the resident changes that they may not need some antipsychotics again for a short period of time, or perhaps there's a period of delirium which will require some medication. I think it's important for everybody to recognize, especially when we're talking about dementia, that is a disease process that, will continue to change the brain and deteriorate the brain. And so what was necessary 6 months ago or a year ago may no longer be necessary down the road. And so attempts to deprescribe should always be looked at, or to at least keep people on the lowest dose possible. And I think when you're talking to staff, because of the concern about resistance to change and why are we doing this, I think it's important to communicate to them the same message. It's not like everybody has to go off and stay off. It is about meeting the residents' needs where they're at, and that if deprescribing is not working, then, we can certainly go back on the medications, but they should be the last resort, not the very first tool out of our toolbox. We should be looking at those other strategies first, and we should be looking at implementing a really good care plan while we're deprescribing, because if you have nothing to go to while you're taking the medications off, then you are going to have some potential issues. So I don't know if that helps to explain this a little better for people so that they feel a little more comfortable with it, but
Yeah, great. Thank you, Cynthia. And I had seen, I think earlier while you guys were presenting, Cindy, a question about whether you would share your progress report. And I just wanted to remind folks that this webinar is being recorded, and you can access that on HEC's website. So if you wanted to revisit anything that Eastgate shared, then it would be available there. I think we have time for, I see one last question to both Cindy Shea or Cynthia, if you want to talk about would an increase in staffing help manage behaviors? And for example, so the question of staffing, and in some of our past provincial scale-ups, we'd actually found the opposite, that in deprescribing, people came back to life and were able to do some ADLs that they weren't previously able, so that there was actually, in some instances, a reduction in those staff hours. So maybe over to you first, Cynthia.
Well, I will say that using person-centered care approaches and deprescribing does offer some benefits. You have residents who are a little more independent; they're able to engage more. So you're actually less intensive with your hands-on care. Consider someone who is really sedated on antipsychotics and requires two people to transfer, two people to do everything with them, versus someone who perhaps can come down on dosage or be deprescribed, where they can participate more in their care. It makes for a different dynamic for sure. And bear in mind, there's always, certainly in Manitoba, you can always refer to the psychogeriatric mental health team if you're really struggling to find a way forward with a particular individual. So let's be honest, are you likely to get more staffing in your budgets? Probably not. So working creatively with what you have and who you have and using your entire team effectively certainly is a positive approach to this. Cindy, do you have anything to add about that with that particular?
Yeah, I agree. We have to work with the staff we have, but with us, we do have one extra staff member, not forever, but just because we have such a mixture right now. That staff member is able to take people for walks, take them outside, sometimes take one or two with them. So that does help with the behaviors as well. And then the other staff can concentrate, on what they need to do, the care that they need to do. So it does help in with the extra staff member in certain circumstances. And I agree, you don't want staff tripping over each other, but you almost have to have eyes in the back of your head on that unit because they're moving quick.
Wonderful. So there's just a few minutes left. So thank you everyone for your questions, and again to our speakers for joining us in the Q&A. So thank you again to everyone for joining us for the launch of this new collaborative. And whether you've previously participated in any of HEC's programming or you're new to these opportunities, we hope you'll really consider registering for this new offering in Manitoba. And if you have any further questions about the program or the supports or how to register, please feel free to reach out to us. Don't hesitate to contact us on the email on the screen here. So like I said, the recording will be available. And then one last quick poll before we let you go. We'd really appreciate your feedback just to let us know if this session was helpful to you. If you could just take a moment to answer the questions that should be on your screen now. The questions are, did this webinar provide useful information? I intend to share what I learned with others. I know more about this topic than I did before participating. What is your gender? And gender refers to the gender that a person internally feels and or publicly expresses. And this is optional. It's collected on behalf of our funder, Health Canada, at their request. And lastly, we're wondering if you intend to register your personal care home for the collaborative. So we'll leave that open for another minute or so. And I just wanted to thank my colleagues here behind the scenes that are producing the webinar, Joanna, Nat, and Alessia and Taylor. Thanks for your support and help. And thanks again to all of the speakers and to all of you for joining us. So that will conclude today's event. Have a great day, everyone.